Good afternoon, everybody. Hello, Elizabeth. Hello, Jean-Louis. I am really sorry not to be with you today, but some circumstances did not allow me to join you. I want first to thank Nestlé, Daniela, Rosa, and Valeria for the kind invitation and the continuous support. And my topic today will be about GI dysfunction, but looking more specifically to machine learning insights and what large database reveal. These are my conflicts of interest. And we know that critically ill patients are surrounded by many therapists, but also a large amount of data is collected from them. This data can be handled using a lot of ways. You can see here in this slide the machine learning process that is or supervised or unsupervised. We can reinforce this learning, and what is recently used is a natural language processing, which is very interesting since it's able to look to all the notes written by the physicians and the nurses and any health professionals. We will try to cover different issues. The first is GI dysfunction using artificial intelligence. And indeed, recently we had a paper published with Metteberger and Adika Reinblaser looking to the strategies of early enteral feeding. And what we were trying to show is that actually we want to start early enteral nutrition and assess GI intolerance and progress to 20 or 25 kilocalories per day, per kilo per day. But sometimes there is some enteral feeding intolerance. And therefore, we suggested in this paper to consider the machine learning models. Well, why is that? Because actually the GI intolerance is quite frequent in ICU. You can see here a number of patients that is increasing with days of hospitalization, but resulting first of all to an impairment to achieve the amount of calories and protein that are prescribed. And the consequences in this paper published by Darren Hyland and with a very large number of patients, you can see 15,000 patients included in this study, that the patients who have an enteral feeding intolerance have an increase in the ICU length of stay and hospital also, but also a longer ventilator stay in the ICU. But even more, you can see that the patients with enteral feeding intolerance have a higher mortality. So this is an entity. So how is AI helping us for that? Well, this is a paper we published 1 month ago looking to a lot of survival forest models in ICU mortality prediction. And this is 3,000 patients that were included with a mortality of around 20%. And we can see that the patients are dying more if they have a higher number of GI dysfunctions. The patients, surprisingly, if they are receiving parenteral nutrition from day one because they have a so strong GI dysfunction, well, at that time, they are surviving better. This is interesting. Regarding SOFA scoring, and I know that Jean-Louis will speak about that, but we were looking to the added value of the GI symptoms to improve the SOFA scoring system. And we looked to quite a lot of patients, 4,500 patients that were analyzed. And we published that already 7 years ago in PLOS ONE. And we could see, first of all, that SOFA score was very strong in predicting mortality. But we decided to include a seventh parameter, which is a GI symptoms parameter, including the energy expenditure daily balance. You can see that the higher the negative balance, the higher the score. gastric residual volume from small volume to large volume and even fecal vomiting, and the bowel movements, soft stools, fecal blocks, bowel management or rectal tubes. And we add this GI symptom score to SOFA, and we use the penalty function to correct the SOFA score when the actual outcome did not occur with the score. And what we saw is actually that even with a GI score in addition to the SOFA score, the advantages were not very strong. And this may be due to the lack of an accepted definition for GI failure, a wide diversity of GI disorders, and no laboratory markers like in creatinine or bilirubin or platelets number. So we don't have so strong evidence for that. So therefore, we decided to go in another direction, which may be a machine learning approach together with a large research team and data scientists. And we published this in Nutrients in 2023. And you can see that we look to enteral fed cohorts, demographics, GI symptoms, lab tests, vital signs, medications, fluid balance, ventilation, optimizing the medical nutritional therapy according to the route, the timing, the energy, the protein, and looking to the clinical outcomes, length of stay, mortality, and rehospitalization. And we added to all these parameters the three features that we found that were mostly relevant: the gastric residual volumes every day for the first 3 days, the GI symptoms, vomiting, diarrhea, GI bleeding, or numbers of GIs in 24 hours, and an inadequate delivery of enteral nutrition in the first 72 hours, less than 70%. And you can see that when we add the GRV more than 250 and an inability to reach 70% of the calorie target, well, we have a better prediction of mortality, ICU hospital 28 days of 90 days mortality, in comparison to the demographics only. And length of stay also is improved in prediction. And the parameters that are showing here, the features, the most top predictive variables for the 90 days mortality are definitively older patients, male septic with GI disease, but also not reaching 70% of the target, and GRV that is higher than 250 at day 0, day 1, or day 2. Well, day 2 seems to be stronger in predicting enteral feeding than day 1, and BMI is also a very strong predictor for enteral feeding failure. It's so strong that people have created nomograms for predicting enteral feeding intolerance critically ill patients. You can see that the primary diagnosis, the failure of the GI Apache score, are giving points, and these points are giving a probability for feeding intolerance. Well, this is helping us to predict GI dysfunction, but is it helping us for the feeding therapy? How can we monitor it as well? First of all, we have to define how much energy we want to give to this patient. So we developed this in a recent paper we published in Current Opinion in Clinical Nutrition. We know that indirect calorimetry is a gold standard to predict what will be the target and decide accordingly. We know that predictive equations can be leading to overfeeding or underfeeding. And we know also that overfeeding is associated with an increase in mortality, so it's quite interesting and important. How did artificial network predict resting energy expenditure? This is a paper published by the team of Martine Laville in Lyon, and looking for obesity and finding that gender, age, weight, and height using an artificial neural network is quite correlated to the measurement of indirect calorimetry. And this is always better than all the predictive equations that are existing. We did the same with almost 1,000 indirect calorimetry measurements, and we found that also it was quite predictive to take into account the weight, the temperature, the heart rate, and urinary output. So physiology and clinical data can help us. We are not as good as indirect calorimetry because maximum error is around 300 kilocalories. Regarding protein, which is also a hot topic and showing that higher protein is not better than lower protein, and 1.3 gram per kilo per day may be the best solution. Not all the patients are reacting the same to high protein. According to our analysis of another papers published in Nutrient 224, you can see that younger patients, higher BMI, less septic, and patients with pulmonary comorbidities, this is a profile that will improve outcome when you administer more protein to these patients. The last point that I wanted to develop is the prevention of nutrition-related complications. Well, here we would propose a change in paradigm and going more toward personalized nutrition. Most of the people today are still treating patients according to their disease, to the disease status. And the treatment is based on the pathology and mainly by comparing groups and randomized controlled trials that will actually give the same therapy to a specific group of patients. If the patients are not receiving this therapy, actually this is a protocol violation. And this violation doesn't allow to include all the patients, so we put these patients out. What we would propose is much more look for the trajectory of the patient, trying to avoid pathology and not to treat the pathology, and selecting the best therapy with a continuous optimization of the therapy. So transforming the guideline-based approaches into a precision guide data-driven therapeutic strategies would be proposed to adapt this complex metabolically demand that are existing in the ICU, this heterogeneity of the ICU patients, to treat them in real time and not according to a strict protocol that will be applied for a specific population. Well, this has been done looking to machine learning and in early feeding intolerance in many studies. Actually, you can see here a series of 8 papers looking using algorithms or nomograms, machine learning, which will be the key predictors and what will be the outcome. You can see that BMI, Apache are coming quite several times, but you will see that also age, Apache to AGI grade, mechanical ventilation, intra-abdominal pressure are very important factors, reaching all of them an area of the curve more than 0.7. This is 13 studies analyzed in this paper, and you can see here in another paper with almost 400 patients, that again, Apache score and intra-abdominal pressure, but also glucose level and mechanical ventilation are quite highly predictive of enteral feeding intolerance. Here is another paper that we submitted recently looking to the type of the enteral formula and the intolerance in enteral feeding in critical care, and showing that according to the type of the formula, standard formula Wainwright peptides, well, you can predict if the patient will be tolerant to the enteral feeding or not, which is also interesting. Here is a long series of systematic reviews. You can see the number of patients that have been included in this series, thousands of patients. Most of them have internal validation reports, but many of them have no external validation reports. And therefore, this is showing the fact that we have to harmonize the reports. We have to improve the validity of the studies by external validations. And we want also to improve the quality assessment of these studies. So in conclusions, ladies and gentlemen, GI intolerance is frequent and is a predictor of enteral feeding failure. But definitively, using large database machine learning can predict who are the patients who will not tolerate enteral feeding and will also let us know when enteral feeding can be optimal. Thank you very much and enjoy the meeting.